Well, hello and welcome to what's going to be a wonderful conversation. Today, I am joined by my friend, Dr. Carolina Sueldo, who is a reproductive and fertility specialist, and we're going to be talking about kind of the health components of the fertility journey, especially as it relates to obesity and insulin resistance and prediabetes and PCOS and all of those challenges that we face. Carolina, thank you so much for joining me today. And I'd love for you to introduce yourself a little bit more.
Sure. Yeah. Thank you so much for having me on. And more importantly, thank you for highlighting this topic. I think it's something that's just not talked about enough. I always say reproductive health is health. And so if we can talk about, obesity, insulin resistance, weight loss journey, all of that, and then in the context of how it applies to a patient's fertility journey, I think we're really serving our patients in a more optimal way. So for those who don't know me, I am Dr. Carolina Sueldo. I am a double board certified OBGYN and REI. So lots of letters. Basically, that means I'm a fertility specialist with years and years of training. My first job out of fellowship was in South Florida. I was then out in Central California for about 5 years and now recently moved back to the South Florida region. So I'm currently at Sabo Fertility Center in Fort Lauderdale, Florida.
Excellent. Well, thank you so much again for joining us. And I completely
Absolutely.
agree. It's like let's bring these conversations into the real lives of our patients.
Yes.
And kind of out of the clinic and into real life. So here we go. So, when I was thinking about our conversation today, of course, when people start talking about seeing a fertility specialist, immediately often the thought goes to procedures and
Mhm.
IVF and, sperm testing and kind of all of those sort of procedural and sort of technical components of fertility. But knowing you, I know that you take a really holistic approach when it comes to thinking about fertility. So I'd love for you to share a little bit about what that looks like for patients who are coming into you.
Absolutely. And for those who can hear my pup Cece in the background, she's my firstborn. She is my baby, and I apologize. She's a little spoiled and barks. Um, but this is life, right? This is full-time working women in medicine.
That's right.
So you're right, Megan. I think, listen, if a patient is coming to me and it is indicated, yes, we're definitely talking about testing and we're definitely talking about treatment. But I think the piece that gets missed, or maybe a lot of times patients are so afraid to talk to a specialist that they wait so long to see me, that we don't focus on just how much can be done before you ever need to see a specialist. When you think about the definition of infertility, and textbooks would say that in women under 35 years old, infertility is unprotected intercourse for over a year, and then for women over 35 years old, we shorten that to 6 months, so unprotected intercourse for at least 6 months. So those women, if you've been trying that long, you definitely need to see somebody. You definitely need to talk about testing. So I don't want to minimize that aspect, but 6 to 12 months is a really long time. And there's
Mhm.
so many things that we can talk about that can precede having to see a fertility specialist. So when a patient is talking to me for the first time, we talk a lot about deep diving into their medical history. And as far as the treatment plan, one of the components of that treatment plan is going to be lifestyle optimization. And so I just want to stop here for a moment and let's dig a little bit deeper and kind of tease that out. What I will say to somebody is, okay, inventory a 24-hour day for yourself. You wake up in the morning, how do you feel? Do you feel rested? How is your sleep? For example, PCOS is a really common disease that I see in the fertility world because they have ovulation issues. Those patients have an extremely high risk for sleep apnea. And if they are an obese patient, they have an even higher risk for sleep apnea. And that's difficulty with breathing when they sleep. That lack of oxygen or improper function of oxygen is definitely a risk factor for infertility. So how is your sleep? How are you waking up in the morning? What is your nutrition like? How are you fueling your body? We both have a colleague and a personal mentor of mine. She talks about loving your body with movement, not only for the aesthetic or beauty aspect, but more so for the physical fitness, the energy, the libido, all the endorphins that come along with loving your body with movement. What's your caffeine intake? Are you somebody that's pounding Red Bulls all day? What about alcohol? Do you frequent happy hour? I remember, I used to be very casual in my questions about alcohol intake, and I had a couple say to me, "Oh, social use." I'm like, "Oh, okay, like once a week." No, we do about 2 shots of vodka every night with dinner. And I was like, "Oh, okay." So let's talk about that,
Social is
right? So
big.
right, yeah. So still social, but in their mind, it was normal. So my point is, you want to be very deliberate and intentional of kind of inventorying your day and looking at things like stress, things like sleep, things like toxin exposure, so alcohol, caffeine, tobacco. We know there's certain professions that might have an increased risk for infertility. So there's actually research done on hair salon workers, firefighters, long distance truck drivers. We think it's something about the toxins that they might be exposed to. So all of this is really, really important to inventory and think about. And as it relates to you and maybe your audience, we want to focus also in on weight. Now, you'll be the one to speak more on this, but a lot of the data in the infertility world is based around BMI, or body mass index. And we know that BMI is not a great marker, but I'm going to speak on it today because that is what a lot of the data is based on. And so a normal BMI, normal, quote unquote, 18 to 25, overweight 25 to 29, and then a BMI over 30 is considered obesity. And we then have 3 classifications: class 1, 2, 3, 30 to 35, 35 to 40, and over 40. And you can just Google BMI calculator, you plug in your height and weight, and it'll give you a number. And so the data shows that women and men who have a BMI over 30 are at increased risk for infertility and do have worse outcomes than patients who are not obese. Again, that BMI of 30 cutoff. So this is something that, when proactively taken, into account, and when action is taken early, by the time those 6 or 12 months come into play and the patient is now coming to see a specialist, they've already optimized for that factor. There may be other things going on that need to be addressed, but they've already optimized for that lifestyle component that I'm talking about.
Yeah, no, I think that's so important. And I'm glad that you pointed out that this happens in men too, because that has been, I think, completely out of the conversation, right? We sometimes get to hear about erections in men, or difficulties that way, libido, but not the infertility piece. And you probably have the answer to this. Does that show up on a sperm analysis, that they would have
great question. Yeah.
less motility or less numbers, or would it be kind of not seen in that?
Yeah. So there's a couple different factors at play here. So the first one is, I will say, infertility does not discriminate. It affects men and women equally. It affects across all ethnicities, all socioeconomic groups. So you are not immune just because you are a man. You absolutely are at risk for infertility. And a semen analysis, if there's a male partner involved, is a standard part of any fertility evaluation. Now, just like in the woman, we know that the semen analysis is sort of this zoomed out big picture view of what may actually be going on. So if we see low count or low motility, those are really pointing to, okay, what else is going on? What else could be happening in this man? The second thing that comes into play is that many adult men in our culture do not see a doctor regularly. And there's been this conditioning in women: you have to have your annual, you have to get your annual PAP. And so we are very accustomed that once a year, we're probably seeing our OBGYN for an annual visit, or our primary care provider, but most men do not. I have a mid-40s husband who is otherwise, healthy and spry, has not seen a doctor in probably at least 5 or more years. And that is true for most men that I encounter in my clinic.
Yeah.
So a lot of times the semen, remember, reproductive health is health. So a lot of times an abnormal semen analysis is actually a reflection of something else going on. For example, If there is poorly controlled diabetes, that can cause retrograde ejaculation. We find no sperm in the semen analysis, and it
Mhm.
turns out it's because of the diabetes. It actually has nothing to do with his sperm production. So these
Wow.
are all really important things to look for. And again, relating back to weight, we know that the fatty tissue in both men and women has an enzyme called aromatase. That aromatase enzyme makes estrogen. Now, I'm not trying to get too medical, but what I'm trying to point out is that that estrogen that's being made shouldn't be there. And
Mhm.
so in women, imagine you and I are having this clear, crisp conversation. That's what should be happening between the brain and the ovary. Now you have all this fatty tissue circulating. So now we're trying to have this same conversation in a crowded conference room. And so
Mm.
that's why you see obese women may have increased risk for menstrual irregularities, ovulation disorders, etc. Now, in men, something very similar happens. The brain and the testicle have to communicate clearly and crisply for sperm production to occur. If you have all of that circulating estrogen, they're now talking in a crowded conference room, and that can actually impact sperm production. So,
Mm.
really, really important that all this lifestyle optimization that we're talking about in women also applies for men.
Yeah.
What we don't see, or what we don't have a way of measuring, is sperm quality. And there's been some attempts at this with DNA fragmentation studies, et cetera, but we really don't have a clear, crisp marker. So when you talk about things like toxin exposures, or
Mhm.
he smokes a pack a day, but he's got 3 kids at home or whatnot, it still continues to be a risk factor because we don't know what's happening at the molecular level of that sperm that could be a risk factor for that couple's infertility. So lifestyle optimization, again, that's an inventory across the board, and that's an inventory for both partners.
Yeah. Well, I think that that's often a jumping off point for me, as well. When we're kind of thinking about health in a couple or a patient that I'm seeing before that fertility journey, right before they're getting started, um, it's a conversation of let's make the changes that are good for our health before we
Yeah,
start a family for more than just that reason, right? So yes,
right,
we've got impacts on fertility, but we also want to build a healthy family, right? When you think about
right.
people sort of coming out of their 20s and 30s when maybe it didn't seem like it mattered so much to, pay attention to their health, to get regular checkups and screenings. And now it becomes more important because you and I are both parents, right? We realize, the importance of,
Yeah,
sort of building that healthy family really from the beginning. So I love that you sort of
yeah.
incorporate those elements. We've talked a little bit about the men, so that's very excellent information. So glad to hear your take on it. Let's talk about what it ends up looking like for the female patients that we see who
Hmm.
have
Hmm.
insulin resistance leading to weight gain or
Hmm.
blocking them from losing weight, or they have pre-diabetes and, plus or minus PCOS, and they're coming to see you. Tell us sort of what those conversations are like and how you help to get people started on their treatment journey towards being able to conceive.
Sure. So I think, again, there's sort of a few different things to consider here. The first one is I will tell you that most fertility specialists and most OBGYNs are much more aggressive about treating prediabetes or insulin resistance than maybe your primary care provider or your annual sort of visit, right? So if they see
Mhm.
something and it's prediabetes, like, well, let's work on your weight, let's, you know, change your diet and come back to me in a year with no real kind of resource to back it up.
Go
For
fix
us, right,
it.
go fix it, exactly. Or the classic eat less, move more, thank you, bye bye, right? And so for us, we know that women who start out pre-diabetic or with insulin resistance before pregnancy are at much higher risk for developing diabetes of pregnancy, and that comes
Mhm.
along with its own host of complications. Anything from increased risk of miscarriage to the need for medications and increased, more intense monitoring. We also have increased risk of big babies, increased C-section rate, increased something called IUFD, which is intrauterine fetal demise. The baby actually passes away for no reason in utero. There's placental issues. So really, really aggressively managing those patients even before they conceive. So someone who maybe has known, maybe they've been pre-diabetic for a year, 2 or 3, and they come to see me, well, I'm going to start them on treatment. I'm going to be aggressive about lifestyle optimization. I'm going to say, hey, what supplements can we incorporate to try and bring these down? Because we know just how important this is once she actually becomes pregnant. So that's number one. Number two is that we know that patients who are obese, plus or minus the insulin resistance, do not do as well with fertility treatment. It's well documented in the literature. They tend to have not as many eggs, if they're doing IVF, not as many eggs at retrieval. They tend to have poor, or I shouldn't say poor, less egg quality than somebody who has a normal BMI. And the implantation, the pregnancy rates are just not as high as somebody who is not obese. So all of these things put together only speak to, hey, and again, one other thing I'll add is in this country, for most patients, fertility treatments are not covered, right? So this is an investment that now they're not only making an emotional investment, a physical investment by coming to appointments, this is now also a financial investment. Right. So all the more reason
made multiple
to try
times because there's a lower chance of success, right?
Correct. So we talk about infertility as a marathon, not a sprint. This is something that requires sort of long-term planning. And that's why, finding a doc that you're comfortable with or a clinic that you're comfortable with is so important. And that's why. But all the more reason, if we know that we can optimize success rates by impacting this issue, why not address it from the very beginning, right? And so for me, when patients are coming to my clinic, typical testing will take about 4 to 6 weeks. We meet for a follow-up visit. We maybe do a lower or less invasive treatment option for the first couple of months. Maybe eventually we're talking about IVF. So sometimes patients are with me for 4 to 6 months and then, before they need IVF. So from day one, consult one, I'm talking about these things. Now imagine if they had a 6 to 12 month lead on that optimization. That would be a game changer.
Right. And I think that's so important to highlight. My hope is that we come, within the medical community to a better understanding of those impacts, because, it's certainly not true that every couple who, has obesity in one of the partners or has, PCOS or prediabetes or diabetes, it's not to say that they can't have a pregnancy or that they can't get pregnant easily, but they're at higher risk for having challenges. Those pregnancies become more complicated. We're hearing from you, that the fertility interventions that are available to them are often less successful. And so I think it's really important that we think more about this. So that's a change that I'm hoping to see. So that we're more proactive in sort of addressing the health and metabolic components. Not judgment on BMI, right? It's really about how is your body metabolizing the food? How are you doing with stress? Right. How are you doing with sleep and nutrition and all those really important components, right? Let's not wait until there's a problem.
I could not agree more. And I think, a lot of time, well, number one, there needs to be a paradigm shift in medicine, right? And we need to be talking about this a lot earlier than by the time they actually get to me as a specialist. Right. So that's number one. And I think we're getting better. I do think we're getting better, but I think we have a long way to go. That's number one. Number two, a lot of times, what I'm hearing from patients is, oh, well, my sister who is 100 pounds heavier than me got pregnant, no problem. Or my neighbor down the street who is 10 years older than me got pregnant, no problem. Yeah. Or, so there's different risk factors that we're talking about. They're like, oh, well, but so-and-so didn't have issues or whatnot. And so my answer is always, look, the infertility is real. That is still there. That still needs to be addressed. What I'm telling you is what are the things that are in our control that we can potentially optimize so that if you do need to go into treatment, you're setting yourself up for the best chance of success. And I think that's the way to think about it. Yeah. So that's a really important point I wanted to make, whether it's weight, whether it's, toxin exposure, medications, age, any of those things, right? Yeah. That we're talking about. Of course, we're going to know someone who XYZ, but this is my case. I'm dealing with the infertility at baseline. And so what can I control? What can I change?
Yeah. It's like, what is the biology in my body
And me, right,
And which
exactly.
is different than my sister, my neighbor, my friend.
Exactly.
Yeah,
And
and what can I control?
I think one other point I want to make, particularly now with this whole onslaught of the GLP-1 agonists, and for those who don't know, that's going to be the names like Ozempic, Wegovy, Manjaro. You probably know more of them than me, but essentially the ones you may have heard in the news making headlines. And these have really look like they're going to be a game changer for the way that doctors are able to treat obesity worldwide. So really sort of, an exciting time for those of us who have really struggled with alongside our patients in that weight loss journey.
Mm-hmm.
And what I tell patients is, at least for now this may change, but at least for now, you cannot conceive while on these medications. And most of them require at least a 2-month washout. So if this is a treatment that might be indicated in your case, it's not something you want to start as you're coming to see the fertility specialist. This is something you want to start 6 to 12 months before.
Right.
In a perfect world, that would happen all the time. Now, sometimes those patients come to me and then I have to make a judgment call and make my recommendations. Hey, this patient is 28 and maybe she does have the time, or she's 38, maybe she doesn't have the time. And so we kind of weigh the pros and cons in a shared decision-making type visit. But it's really important that, hey, if this patient who's been trying for a year and a half was made this, this option was made available to them, they were made aware that this was a possibility for them. I think some doctors are still afraid to prescribe it. I know in my world, a lot of us are still very tepid about what to
Yeah,
do with them.
they're
Um,
new.
right. And
New.
so if
Yeah.
this is something that could potentially be started so, so much further in advance, then it wouldn't have to be an either or by the time they get to see me. So I think
Yeah.
there's some really important things to highlight as we're
Yeah.
talking about this.
Yeah. And I think, I'll jump in there with a few points. I think you and I will both very readily acknowledge the lack of proper knowledge that has been taught to us, about the biology of
100%.
obesity and, the very real struggles when we are trying to lose weight, when we have insulin resistance, when we have some of these metabolic, issues going on. All the effort that you're throwing at trying to make improvements are like you're running up against a wall over and over again. And what these medicines have been able to do for us is to have a new tool to be able to sort of break through that wall. And there's lots of very real challenges to those medications right now. There's cost, there's shortages, there's lack of insurance coverage. That's actually what I talk a lot to my patients about, is the same way that infertility treatments are often not covered by insurance.
Mm-hmm.
Many of these weight loss medications are also what's called an insurance rider, that the employers who provide the health insurance have to opt in or opt out of. A lot of patients will
Okay.
come and see me and they'll say, I have great insurance, like I hardly have to pay anything. That doesn't matter. It matters who
Right.
they work for right now. And I think you and I can both agree that this causes challenges in my world, just the same way
For
that
sure.
patients coming to see you, come up against those financial struggles, and it's a real
For sure.
problem.
Yeah.
Yeah. Yeah.
Absolutely.
Yeah. So that's really helpful. And when someone is, let's say they've been diagnosed with PCOS and they are, maybe considering maybe just doing the lifestyle things and trying to get, really intentional about that, or perhaps they're using medication to really kind of help balance their metabolism better. What does the data say about how much weight does a person have to lose? Because I know for my side of things, often people think, well, the goal is that I get down to the weight that I was in high school, or the goal is that I have to lose 100 pounds in order to be able to do this.
Sure.
And, there's not perfect data, but there's better data than that. So what are we
Yeah.
looking at when it comes to PCOS?
Yeah. So I think there are kind of two groups that I want to talk about. Specifically with PCOS, specifically patients who are obese, because I think it's also important to note not all PCOS patients need to
Correct.
lose weight.
Correct.
For the PCOS patient that also has obesity, those studies show that approximately a 10 to 15% weight loss in their body weight, many of those patients, those cycles return to normal. So there was a normalization of their menstrual cycle, ovulation, spontaneous ovulation returned, which is huge for PCOS patients trying to get pregnant.
Yeah. And so if we're talking about someone who, I'm just going to throw some numbers out there. If we're talking about someone who weighs 200 pounds, 10 to 15% would be 20 to 30 pounds. So
Yes.
not getting all the way down to 120, for
100.
example, which is not usually
yeah.
a very realistic goal, even with medications.
Correct.
But we're talking about 10 to 15% of that initial body weight.
Right. And so I think that is really concrete sort of numbers that PCOS obese patients can hang their hat on. Now, outside of that, the waters get a lot more muddy. So it's really not as clear. What I can tell you is that in the IVF data, generally speaking, what we found is that patients who had an obese BMI had worse outcomes. Patients who had an overweight BMI did not. So there was no significant difference between normal and overweight. There was a significant difference with the obese category. So when you're plugging in that BMI calculator, and again, I'll defer to you on the validity of BMI and other tools that we can use, but if you're plugging in your BMI calculator, height and weight, you just want to play around with that number. And most of the time, it's not a huge drastic high school drop. Usually it's going to fall somewhere in that 10 to 15% range, but you just Google BMI calculator, you can plug in the number and you can find a target goal weight for yourself based on your height.
Yeah. Yeah. And I think that's really important to highlight. And, as I've discussed before in some of these videos, we know that BMI is a very imperfect tool. It unfortunately has racist origins, like many, many things that we're unraveling more. And it doesn't distinguish between people who have a more muscular build and people who have a more slight build. It probably misses people who have more central obesity, kind of around their trunk and their abdomen, but especially have really slim arms and legs. There's a number of things that make it a challenging metric, but it is kind of one of the tools that we have, right, when we're sort of looking across big populations of patients. And so I think, in our discussion, yes, it's important to highlight that, the data doesn't drill down into a particular patient's experience, right? We can't guarantee that if they move from a BMI of 32 down to 28, that magically they'll get pregnant. But what we do see in the data is they're less likely statistically to have challenges, at a BMI of 28 compared to 32.
Yes. And I think for me as a science person, I never really got this until it was a gym owner in California. She and I had this conversation, and she doesn't know this, but she forever changed my perspective. And so she said, from a biology standpoint, science person, right? Think of any other species in the animal kingdom: horse, gorilla, cow, dog, whatever. There are not just male and female, but there are hundreds of different species, right? And all of those different species require different set of nutrition. So, a thoroughbred versus a pony, or I don't know, different dogs, and all the different varieties of dogs. Right. Yeah, exactly. So, and it just was such an aha moment for me, like, oh my God. And it seems so simple, but until she put it in that context, it was never really visualized in that way for me that, yeah, you're right. Like, humans are not just men and women. There are hundreds of different species with hundreds of different builds, and the nutritional requirements are going to be different for each and every one. That was a real pivotal moment for me, at least in the way I counseled patients with their weight and their health journey.
Right. And just their tolerance of different diets, right? If we just even look across, what is kind of an optimal set of foods that somebody metabolizes well, it's going to be different for different groups, right? Depending on, on their age, their ethnicity, their activity levels, their, there's all kinds of different factors, right? and it comes down to, we don't just have one easy answer that works for every
Exactly.
single human body, right?
Exactly. And
Yeah.
touching on that just so briefly, I always tell my PCOS patients, for example, the keto diet that's really popular and trending, intermittent fasting that is really popular and trending, both of those we know to actually be really not good for PCOS patients because of their
Mm,
diabetic tendencies. And so when you're doing these diets or nutritional plans, you really want to make sure you're working with someone tailored to your disease. Another classic one in my field is endometriosis. Endometriosis is an inflammatory disease, and you really want to focus on anti-inflammatory type diet. And really what that means is whole foods, right?
right. Real
Unprocessed,
food
which is
as
what
it's
we, yeah,
grown.
what we should be eating anyway. But my point is in this, if you are going to have a multidisciplinary team, if you are going to be working with a nutritionist or dietitian, just make sure that they know, that they're trained to tailor things to your specific diagnosis.
Yeah, I think that's such a important thing. And don't I think within, when we look at the hierarchy of medicine, right, there can be this perception that, oh yeah, the referral nutrition's not as important as
Mm-hmm.
my referral to go see the fertility specialist, as my this or that, physician who's going to be treating me. But as you and I both know, our nutrition colleagues, especially those who specialize in some of these particular sort of health niche areas, such as optimizing PCOS, such as insulin resistance and prediabetes, like, we really need them on the team
Mm-hmm.
in order to be
Mm-hmm.
able to do more of that deep dive into, being able to look at what foods are working for somebody and what foods are
Mm-hmm.
causing more issues. And so, I think that's really thinking about it as, this is the team of people,
Yeah.
of expert specialists who are helping me to
Right.
get to better health, which allows me to then have these health goals, right? To become pregnant, to start a family, any of those important endeavors.
Yeah.
Yeah.
Absolutely.
Yeah. Well, very good. Thank you so much for joining me. I think this has been a really
Yeah.
wonderful conversation, sort of looking into some of these issues in a little bit more detail. And, I just love the chance to be able to sit down and talk with my friends who are specialists and really sort of pick your brain about,
Oh,
what can
thank
we do?
you.
Because you know, patients don't really get to benefit from our conversations that we have. And
Mm-hmm.
I really
Mm-hmm.
think that they could get so much out of it when they see how we are able to interact and sort of help each other help take care of our patients. Similarly, they can benefit. So I'm so glad that we took the time to
I
do this
love
today.
that. Yeah, and this is such important work that you're doing. And for me as a specialist, what more could I want than a patient who's already coming in as optimized as possible? And as I said in the beginning, you still have infertility. We're still, may have to talk about testing and treatment down the line, but this is a patient who's already addressed all of these other things that I don't have to. So,
Yeah.
yeah, absolutely. And I agree with, having these conversations and hearing how we're thinking about the problem and hearing how we would love to see the problem managed in an ideal setting.
Yeah. Yeah. All right, friends, that's what we have for you today. Thank you for tuning in, and please be sure to refer your friends to us to listen in on the conversation. Have a great rest of your day.
Thank you so much.